All right, so I have this time for 30 minutes. I'm not sure if I can make up too much time, but I'll try. First of all, thank you for having me, and it was really inspiring to hear the other speakers, and also just see all the young future leaders and current leaders out here. On a personal note, my mom left China and Japan during the war, or after the war, and was really determined to be a physician. And she was fortunate to get a full scholarship to what was then an all-women's school, college, Vassar, to which she's forever indebted for changing the course of all our lives. But she ended up being one of 3 women in her medical school. And it was a challenging time, I would say, being one of 3 women and also the only woman of color and who spoke with an accent. So I am always reminded how grateful I am for the many, many women who have paved the way for those of us in medicine now. So I have nothing to disclose except that I invest heavily in these 3 individuals. My oldest I had as a resident, and the twins I had when I launched the Pediatric Leadership for the Underserved program at UCSF, which is a separate match residency program I'll mention briefly later. So the residents tease me and say I had triplets in 2004. So what I'd like to just do is, in this brief time, is to impart a little bit of an understanding of what we mean by child health equity, why it's important, and how we might be able to achieve it. So raise your hand if you are a mother, and keep your hands up. Grandmother, aunt, uncle, godparent. Raise your hand if you were born. You were a child. It may be the most unifying thing we have, especially these days. And if you think back to what made you, as a child, in your early years, what enabled you to be who you are today and be successful and supported you, and especially perhaps in difficult times, because in those difficult times, those can be defining moments for us for what's really important and what's really helped us. So if we really think about those things, those are foundational elements that every child should really be surrounded with, so that they can also become successful adults. But something happens when we're born. When we're born, so the blue is healthy and the red is unhealthy. And so when we're born, actually 95 to 97% of children are born healthy. Yet when we become adults, 50% of us end up with one of 6 common chronic illnesses, such as asthma. And 3% of adults say that they live healthy lifestyles. So I don't know what we can do to try and preserve what we're born with, but we were born with a pretty good set of of healthiness that if we could only learn to sustain, it would probably create a lot of healthier adults. So what do we mean when we say equity and disparities? So health disparities are really just differences in health amongst different groups of people. And I like this cartoon because anyone see this cartoon before? I like it because it really helps visualize the difference between why equality does not necessarily lead to equity. And that also to achieve equity, in the third panel, you can see that to achieve equity, it really means addressing some of the systemic and historically placed barriers that we have for certain people. The reason why I don't like this slide, and I found a different one that I'll show you in a second, is because you can see that the people are different sizes, which suggests that inherently there's differences between people, and some people, are genetically or inherently not as, not as tall or not as capable. And then I found this slide, which I think really captures it well, because it speaks to the fact that historically and systemically in our society, we have had barriers for certain people. So in order to make up for those differences these barriers that we've placed, we need to make adjustments so that we as a society can fully benefit from every individual's capacity. So every clinic, I practice at our public health hospital, San Francisco General, and every clinic session is a reminder of the daily struggles that our patients and families face. So even if you can't really read this or know what this is a growth chart. On the y-axis is weight in kilograms, and on the x-axis is age in months. So you can see that on your left is a nice curve, and that's a normal baby growing at about the 25th to 50th percentile for their age in their first couple of months. On your right, you can see that's a very different growth curve, and that was the patient we saw. So from the beginning, was born at a lower weight, and then that is a very abnormal curve because started gaining weight and then just started plateauing at about 2 to 3, 4 months, which is really abnormal and usually ends up, ringing bells and lots of tests and possible admissions and cardiology workup because you're trying to figure out why in this critical growth time the baby's not gaining enough weight, and led to many, many more visits. We started seeing her 1 or 2 times a week. We started noticing that she would gain weight on the weekends and then start losing weight on the weekdays. And so we sat the mom down and I said, walk me through your week. Like, what does your week look like? And she said, I'm really fortunate because I'm an early child care provider. And as a side note, that is the most valuable underpaid position we have with not a lot of benefits, if any. So she didn't have the luxury of having paid parental leave. So she did feel lucky because she was able to bring her baby to work with her. But she said, in quotes, ironically, doctor, I'm too busy taking care of other people's children to take care of my own. So she would breastfeed and then have to prematurely end breastfeeding in order to take care of another child. So she was very, very committed to breastfeeding, but she ended up having to give formula. So the solution was nutrition, basically. It wasn't some fancy tests, some fancy medicine we had to give this child. They just needed adequate nutrition. And while formula was a solution, the ultimate solution really was paid parental leave and the ability for these families and these parents to be able to adequately take care of their children. Later that day, I saw my 12-year-old patient who came in for chronic abdominal pain. And in our electronic medical record, we have started embedding social screening. So we have embedded food insecurity screening. And so when I asked her, at the end of the month, does your family ever run out of food? This is very common, especially in San Francisco, where it's really expensive to try and normalize it. She said, yes. And I said, so you're hungry sometimes. And young teenagers, they don't really say a lot usually. So she said, yes, I'm hungry. And I said, what do you do when you're hungry? And she said, well, I drink a lot of water. And it gets me mad. I get emotional because I get emotional when I'm frustrated. And I get so frustrated because it's crazy to think that in these critical developing years, children are drinking a lot of water in San Francisco and the Bay Area and California across the US in order to feel full. I can show you a multitude of slides with the different health outcome, an indicator that's broken down by race and socioeconomic status that looks similar or worse, where there are disparities in health. This happens to be one on asthma broken down by race. And I can also show you different slides that show that where you live determines what your health is. So these are 2 communities in San Francisco, two communities in San Francisco, 2 communities in Oakland. Remember, San Francisco is 7 miles wide, so it's a very small area, and yet we have very different outcomes depending where you live in our city. And across the lifespan, so prematurity to poverty rates, to vaccine rates, to reading attainment, all the way to lifespan. There are pretty vast differences depending on where you live. So why is this important to women? Here we are at AMWA. And I would say that you probably intuitively understand that child health disparities are very closely linked to disparities for women. And so we know that over the decades, the number of households with 2 parents has dramatically declined. About a third of households do not have a male father type figure present. That's 15 million children in the US and 5 million additional children without a mother. And this is a busy slide, but if you just look at the gray, the tannish part, the tan part is the number of black children who are living with just a single parent. And so the top's broken down by race and the bottom by educational attainment. And black children have 54% living with one parent. Same with those who have only less than a high school degree, about 50%. And we can't just throw statistics around there with again acknowledging some of the systemic barriers that are in place and why this might be. So if anyone, has anyone seen the documentary 13th? Yeah, it's a very powerful documentary. I highly recommend. It's on Netflix. But it speaks to the 13th Amendment and how this has embedded in our society, in our Constitution, mass incarceration of colored people. Because when we abolished slavery, there's a little clause that says, we abolished slavery and indentured servitude unless you've committed a crime, which then almost immediately led to mass rounding up of former slaves into prisons for basically indentured servitude. So anyway, it's not probably surprising, but there are statistics about the number of, if you're a single family household, especially with single female-led household, you are much more likely to be in poverty. And that's basically what this slide is showing. So there's things we can do. There are policies we can make that can help single family households and all households and families. If you look at other charts, it shows that basically by having children, you're putting yourself at higher risk for being impoverished and meeting the poverty level. But there are things we can do, and there's a lot of threats to child well-being, as you can see here on this slide. And we know that if you invest early on, and the earlier on the better, every dollar you invest, and there's a wide range when you look at just something like high-quality early education, every dollar investment gets anywhere between $5 to $12 return over the life course. And so if early childhood investments was like a stock, it would be like the hottest ticket on Wall Street. Somehow we have not done that yet. So what are the solutions? What can we do about this? One, it's going to take a different approach. We need new types of leadership, and I really appreciated this article called The Dawn of Systems Leadership, because it speaks to how these complex societal embedded issues like poverty and global warming are going to require unprecedented forms of collaboration. And in the psychology and business literature, if you look at the studies that look at things like transformational leadership and the type of leadership that we're needing to address systemic changes, it really shows how transformational leadership, which really encourages so-called followers to take risks, these are leaders who are visionary, who encourage people behind them to come up. That is a style, when studied as a whole, women as a group are more likely to have that kind of leadership style. And so I would say that we are the ones who are going to be able to tackle these really big systemic problems because it really requires a much more collaborative nature, which as a whole, women have been studied to find to have more of a leadership style in that way. We also, in our purview, have how we train people and our educational programs. This is what we need in order to create systemic changes in communities are different tools in our toolbox or in our black bag than perhaps we've been traditionally trained with. And that was the premise for starting the Pediatric Leadership for the Underserved Residency Program, where we're embedding hardcore leadership skills into the context of a standard clinical residency training program. And we're really just envisioning sending out a cadre of physicians who are empowered and have skills that are allowing them to transform healthcare. It's really gratifying because they're all over the globe and all over the US, in government, in nonprofits, in academic institutions, and in the community, leading change for vulnerable populations. And I would say about every other week, I either get a text, a Facebook post, because they made me sign up for Facebook, or an email just telling me about, I literally would get a text just saying, hey, Anda, I just want to let you know I'm using these leadership skills every day in my job. I also wanted to just mention that there's a lot of smart people in large organizations who've been thinking about this. What do we need to do to transform communities? So this is a busy slide, but it's more for you just to know that the CDC has something called the Community Health Improvement Project, or initiative, and you can go to their website, and they have a lot of different frameworks really helping us walk through what it's going to take. And as you can see, it's going to take a lot of collaboration with different stakeholders. Similarly, RWJ, the Robert Wood Johnson Foundation, has their Culture of Health initiative, and they have this very interactive framework. So if you click on any of these boxes, it will lead you towards a whole, their entire framework. And, you know, local action in addition to national movements, but there's the importance of local movements is critical. So we here started the Child Health Equity Institute, which is a cross-bay, cross-sector entity with Oakland and San Francisco. And really what we were trying to do is leverage our expertise as an academic institution and as a healthcare industry or institute in partnership with the expertise of all the many stakeholders in our community and government. And what we see as our areas of expertise are those the balls there, healthcare education, research and policy, and clinical care innovations. And how do we bring those, make them accessible to the expertise of our stakeholders to really create a laser focus on improving the health of children? Our vision just kind of gets back to what we did at the beginning when I asked, like, who's been a child and who's been born, and what are the fundamental things that allowed you to be successful? Those are things that every child should have. So how do we create healthy children, no matter all children being healthy and well? And how do we leverage our expertise and in partnership to do that? We have multi-sites, so a lot of this, and I say this because I think this is true for other initiatives like this in other localities across the country, that a lot of it is just really trying to break down some of the silos that exist in our institutions. So we have multiple sites, including our public health hospital where I mentioned I work. And how do we really leverage the expertise occurring in all these different pockets here and make it accessible to the community and our local stakeholders? We follow a collective impact framework. Some of you guys have probably heard of that. It seems to be like the hot buzzword it's probably already out of touch or something, but it's still been effective. Basically, collective impact, and there's a lot of frameworks out there if you Google it. It is a structured way of trying to of a multi-sector, multi-collaboration effort to create sustainable, lasting, and impactful social change. And so there's a whole framework and steps that you work through. So part of what we had to do is bring together the many stakeholders at UCSF. We have 9 champion entities that are involved with child health equity, along with over 100 stakeholders, including community organizations and our local government. When we got our stakeholders together and asked, like, what really should we focus on at UCSF and what can we do to help? These are the areas that we landed on. We were only a year and a half in existence. is to, one, really build that network, serve as like a backbone, and really increase the ability to share data and the power of data. Leveraging our research in partnership with communities, and we have a grant to support this where we're trying to create the infrastructure so that our families and patients can tell us what's the most relevant research we should be addressing rather than us trying to like recruit patients all the time, but maybe it's not even the most relevant question. Addressing unmet social needs through our clinical programs. I've alluded to some of it, like what we can embed in our EMR and our electronic medical record as an example. And then cultivating a diverse workforce through our pipeline programs. I'm not going to go through this, but there's over 30 programs that we've started in partnership with Oakland. As you can see, a lot of them are not what we would traditionally call clinical functions, but it's really what we have to do to address child health in the broadest sense. So we've talked about what institutions can do and health professional institutions. What can local governments do? And local government is one of our key partners. This is Maria Sue. She was a former clinical psychologist at our public health hospital, and now she runs the Department of Children, Youth, and Their Families. So this is a unique proposition-funded San Francisco department that takes $3 out of every $100 made from our property tax. And if everyone knows how expensive real estate is here, so we have a lot of money. We have $70 million a year from this for the 120,000 children, which is not a lot in San Francisco. And how many of those 120,000 children really are in need? So the numbers are manageable. We should be able to do this. We have money. We should be doing better. And so there is the woman who really had the vision of this proposition and this sustainable tax base for children. Margaret Brodkin has launched an initiative where she's trying to bring this idea to other municipalities throughout California. The other recently passed voter-based proposition is Our Children, Our Families, and it's basically so that it sounds kind of dry, but it's so that our local government created this framework and really tried to leverage so that we're all using the same outcomes and metrics to make sure that we are all working towards the same goals. And so to make that a little more concrete, they have this outcomes framework. It's all online. But basically, they through broad stakeholder engagement, they landed on 5 goals for children and families in San Francisco, 19 measures of success, so that we are all using the same metrics, the same outcomes, and they can channel those $70 million to those who are most in need. What else can we do? We can leverage data. We are in the science realm, and we have analytic power, or expertise at least. And we should be using those in partnership with our stakeholders. There are really interesting organizations. This is Children's Data Network, where they're breaking down the silos of data and getting license agreements in place so that you can share data across different agencies so that we can get a whole picture of each child, why we shouldn't be able to use more precise techniques to make sure we're identifying the need of children better. And that is what this is trying to do. Other countries are way ahead of us. This is Australia's Center for Community Child Health. The Silicon Valley Data Trust, similarly, is merging data from 3 counties. And this is my colleague, Robert Kahn, in Cincinnati. He has used geocoding to identify the hotspots of asthma throughout Cincinnati. And he's identified them in basically the hotspots are in poor housing units. So what he's done is partnered with the Legal Aid Society so that advocates can then advocate for maintenance for those housing units and improve the housing conditions of those families. And now they've embedded the Legal Aid Society in their electronic medical records so they can more easily make referrals, et cetera. Similarly here, to make these examples concrete, with the Our Children, Our Families initiative, for those 19 measures of success, one of them is preterm birth. When we started looking at the data, we found that really the largest disparity was in African American moms living in 5 zip codes, and not ones who had spontaneous deliveries preterm, but ones who were induced because of poor maternal health. So you're really kind of drilling down and trying to figure out exactly, like, if you're going to target, what is the population to really target? That's preliminary, so don't quote me on that yet. But it showed me the power that we have in the data. What is the role of policy? And we heard many examples already this afternoon. We here recently signed $15 minimum wage for California. I think it's nationally set at $7.25, which is crazy if you live here. So really, how do we lift families out of poverty? And you saw already earlier when I showed what it looks like for single-family households, especially single-mom households, where they're making $24,000 a year, as opposed to the average families is $80,000. So minimum wage is a huge step. I think Massachusetts and New York similarly have higher minimum wages, similar to California. The other area is in fully paid parental leave. We are the only country besides Suriname who does not have paid parental leave in the world. So San Francisco became the first city to pass this, where we're mandating 6 weeks paid parental leave. The dialogue around this in the media was all about the impact on small businesses. So we partnered and wrote op-eds with our child advocacy organization partners to really try and change the narrative around what does this mean for families and children and child development and all the things we talked about earlier around the life course. And those are things, I think, again, which we've heard earlier as well, is the role we can have in changing the narrative around these policy decisions. So, checking the time. Okay. I hope that I've left you with a few things and piqued your interest and imparted a little understanding that, one, we have an opportunity to improve health and well-being for children and that leads to health across the lifespan by investing in children earlier the better and for families. That it's going to require a different type of leadership. One, a type of leadership that all of us actually can do, and that we're a part of that change in narrative. We can also create movements in the things that we actually are empowered to change, like education, the research and policy we do, and our clinical care. And that with the analytical and scientific expertise we hold, there's a lot we can do to help people understand the data better. We can use our voice to change the narrative. And I remember there was a book that I give all the PLUS residents called The Cathedral Within by Bill Shore. Has anyone read that? It really speaks to that these movements often last longer than our lifetime. That the master cathedral builders have a vision and work tirelessly toward the vision, knowing that they're never going to see it to its fruition. And each chapter of the book highlights different examples of this, from the Harlem Children's Zone in New York to the Chicago Children's Choir, and people making a difference knowing that the change may take longer than their lifetime. So I highly recommend that book. It's really inspiring, and I like this quote because it reminds me that often the barriers are actually stepping stones. This is my last slide. At heart, I'm a medical educator, and these are two of my favorite quotes. The mind is not a vessel to be filled, but a fire to be kindled, and even more relevant perhaps today, in times of change, learners inherit the earth, while the learned find themselves beautifully equipped to deal with a world that no longer exists. We need to train ourselves differently. And this is my email. I welcome anyone to contact me. I'd love to work with anyone who's interested. Thank you.